Hello and welcome back to the Advancing Healthcare Innovation Show. I am your host, Michael Stamatinos. And if you're new to us, man, we are really excited to have you here because we're having some incredible conversations with just some amazing leaders that are painstakingly reshaping the future of healthcare. And we're passionate about a number of different areas. We're passionate about access and leadership and innovation adoption. And if it's your first time tuning in, let me just take a quick step back and tell you a little bit more about what we're doing here. So we are focused on bringing real stories of innovation to life with real leaders that are in the trenches getting things done. And we're not just talking about the things that are working, we're talking about learnings, and we give our guests the platform to be able to share their stories with our community and ultimately with the world. If you haven't checked out any of our historical interviews, wherever you're ingesting this information from, whether you're watching it or listening to it, please, would you mind hitting the subscribe button now so that any of the new interviews come directly into your inbox? In our field, they're consistently evolving, and it's crucial to have leaders that can envision a future differently, that are eagerly embracing innovation to address a lot of our pressing challenges. And we have no shortage of challenges, which means that there's a ton of opportunity to innovate and make things better. So our next guest on the show is one of these leaders, and we are honored to introduce Dr. Orsula Knowlton to the show. Dr. Knowlton is a trailblazer in healthcare. She brings over 25 years of experience in shaking up the way we manage medications and care for patients. As the co-founder and chief strategy officer and innovation officer at GalenusRx, Dr. Knowlton brings unparalleled expertise and experience and passion to the forefront of medication risk management. We'll get into that a little bit more today, but her work is really dedicated to transforming industry practices by developing patient-centered solutions to meet and exceed the evolving needs of healthcare providers and patients alike. So prior to GalenusRx, Dr. Knowlton co-founded Tabula Rasa HealthCare, where she steered the company from a startup to a market leader in the high-stakes arena of value-based care, especially within the PACE, so Program for All-Inclusive Care for the Elderly. And they took 40% of the market. So she knows a thing or two about growth. And Dr. Knowlton's achievements, I mean, they've earned her widespread recognition across the industry. She's received numerous awards throughout her career. And just beyond her professional success, Dr. Knowlton has also just committed her time and expertise to various boards, contributing to nonprofit, private, and public organizations alike. So today, we get to dig into that impressive body of work and focus more on some of the things that she's working on today with GalenusRx. Dr. Knowlton, it's a pleasure to see you. Welcome to the show. How are you?
Thank you, Michael. Thanks for the kind introduction. Things don't happen out of happenstance. Things happen because you have a great team. And we've just always had great teams and people around us to support us and support the vision of medication safety. So thank you.
Yeah, it's my pleasure. So take me back to the moment when you realized that, pharmacy wasn't just a profession for you. It sounds like it's been your calling. What made you say this is where I want to plant my flag?
It wasn't a direct line or anything like that. My grandmother lived with our family growing up. So from 0 to 18, I always had my grandmother, which was great because she saved me so many times from my mother. Uh, but I saw my mother struggle with being the caregiver, someone who's a first generation, sorry, zero generation, I'm first generation Greek, and she really struggled with understanding her medications. And she lived to be 94, and she was on several heart failure, respiratory, pain, arthritis medications. And I couldn't really help her. And I felt so bad that,
Hmm.
it's all these pill bottles and trying to figure out how you open one every single day and when to take what. And my grandmother had a lot of what I think were adverse drug events retrospectively. She fell a lot. She passed out often. She would be confused on her walk. She'd go sit at another house, and we'd have to get a search party out to find her. And I really felt that that was, when pharmacy became, someone married into my family who was a pharmacist, and he talked to me about pharmacy, and his name is George Millilly, and I have to thank him for getting that idea in my head that I could
Mm,
be. I never thought I could be a pharmacist. I always thought I'd be involved in the family restaurant business, but I was also told that women don't enter the family restaurant business, so it kind of was a clear path to the pharmacy profession. But really, what drove me was the caregiver experience of my mom and really trying to change that for other caregivers and patients.
yeah, it's amazing to see how things that we experience in our lives leave these impressions, and sometimes those impressions can lead to lifelong pursuits. Has there been a moment from your early days, maybe as a student or when you were doing your clinical rotations, that still influences how you lead today? You mentioned something about building a great team. I'm just curious, are there any influences that you use that you still include in your leadership style today?
Absolutely. I went to the University of the Sciences, Philadelphia College of Pharmacy and Science, which is now part of St. Joseph's University, Jesuit school in Philadelphia. And I just had the most incredible experience there with faculty, being involved with the American Pharmacists Association as a student, and really embracing the profession as a part of who I am. And I had several mentors through college and then after, including our co-CEO, Calvin Knowlton. My husband has been a great mentor to me. So I have so many people to thank. I couldn't even start. And
Mm,
having said that, I love mentoring people as well. I feel that having the opportunity to help shape someone's future and their, supporting them in their career is pretty rare. People really need support to get to the next level. And it's
right.
always such a pleasure to do that.
Well, we'll talk about that in just a little while because that's an important aspect of leadership. And when I want to maybe shift gears just for a moment around your current venture, and we can kind of weave in some of your other interesting leadership stories from Tabula Rasa and other ventures into this narrative. But if you had to explain GalenusRx to a 10-year-old, um, what would you say? How would you explain GalenusRx?
To a 10-year-old, well, I think the way I would explain it is that if you think about medication and you think about a parking lot and how medications, in order to get in and out of the parking lot, they need these various proteins to be transformed, whether it's to
Mhm.
be activated into the parking lot or to be let out of the parking lot. And that's what your body does. Your body either is activating medications or eliminating medications and transporting them around your body to where they need to work, and digesting your medications. However, when there are other cars in the parking lots, the cars that are trying to get in don't know what to do, so they end up just hanging out. And sometimes for medication going into the body and seeing all these cars in a parking lot, it just hangs out and creates side effects, or it could
Mm,
have an accumulative effect. So what we do is we have developed a way, let's call it a dashboard or clinical decision support tools. I wouldn't say it to a 10-year-old, to really help identify, well, two things. One is to help identify in a population the medication regimens that are putting people at risk, and then on an individual basis, not just that, but also how to reduce that risk. And often
mm,
it's as simple as separating out when you're letting the cars in the parking lot, meaning how people take their medications. And not a lot of thought is really given to that in our health system. People have five or more prescribers, physician specialists that they see, and often nobody wants to change a medication regimen of another physician, which really puts the patient sometimes, at risk of a problem. Well, they'll have to go to the ER, or they'll have a hospitalization, or even end up in a nursing home due to a fall, or even die prematurely when they could have had a much longer life because of that. So our goal is to really help clinicians identify and value-based care organizations, reduce the medical costs that are attributed from adverse drug events.
I love how you talked about the parking lot, that vision of a parking lot, and how things can get messy and blurred it seems as though that the way that you described it, how come this hasn't been sort of organized, disrupted sooner? What is existing state prior to GalenusRx? And what was it that made you say, well, there's got to be a better way here? I mean, what are you up against? Are you up against just, like you said, just people being okay with doing things the way they were being done for a long time? Like, how does that level of disruption occur?
Well, it's very interesting because pharmacy was the first profession to be digitalized. So in back in the 70s, pharmacies had computers and they
Yeah,
worked to get paid. And along the way, the individuals, the database companies that were making payments based on NDC numbers of drugs and the strength and the quantity decided, you know what, we can actually look at drug interactions this way too, based on what's in the literature and what's been published, what the pharmaceutical company has published. So they put together this drug interaction system, which is still looking at one drug to one drug. And that worked fine for a while when people only took, drugs when they were sick. And then as drugs became more for chronic diseases and people were able to manage not just one chronic disease, but multiple chronic diseases, that system just doesn't work. And in fact, the Office of the National Coordinator of Electronic Health Records requires to be certified that you turn that system off because it delays people from doing their job. So on an individual basis, a person can turn off that system in their electronic health record just because nobody can look at, of 10 drugs, there's probably 100 drug interactions that can occur. And an individual doesn't have the capacity to do that. It would take 40 hours to figure that out.
yeah.
Some
Just think about the computing power that the brain would have to do to be able to do that. And
and to
so,
know and to know all that
and to
information.
know. So instead of them not knowing that information, do they, and please don't take this the wrong way, do they just kind of turn a blind eye to it and go according to what their specific treatment plan is, even if there are multiple clinicians involved? And
I don't think
like,
I don't it's not really a individual's problem. It's really a systems problem. So I would never
okay,
blame an individual in the healthcare system,
right,
except for
right,
pharmacists, because pharmacists often in the various capacities, and often the physicians will assume the pharmacists will, and they have, right? There's so many pharmacists, often physicians will say, love pharmacists, they've saved me, from
yeah,
something really bad happening to one of my patients or several people in the past. So people love pharmacists, but in a capacity of a real high volume operation, pharmacists are very limited as to even their ability to stop and think, um, alone the technology that really is not providing them the information they need to make the changes to a medication regimen or to make the recommendations to a prescriber or provider about how to change the regimen to be safer. And working with patients directly is really what we do. We engage, we understand, to reconcile a person's medication profile is completely different than getting their medication history from a record.
yeah,
Because how they take it, what over the counters, what herbals, what recreational drugs, I mean, all that is important to understand that. But patients really love the experience of having someone completely interested in their medications. Typically, people are interested in understanding what you're taking, but that's it. There's no real counseling on what the drugs do, what the risks are. They see a lot of commercials on television, and we're the only
right.
one of two countries that have direct to consumer advertising. New Zealand, which is now repealing their direct to consumer
Mm,
advertising. And even worse now, the companies, and I don't mean even worse, they're great companies, but if you're not a manufacturer of a drug, you can have a commercial about a drug that does not have any risks or warnings related to it. And there was just a Wall Street Journal article about that a couple weeks ago. I don't know if you read that.
wow. You mentioned pharmacists, and when I think about pharmacists, my my thought goes to they're way more accessible. They're a way more accessible clinician than they are to get in front of a physician. And for me, I mean, at least pharmacists have been sort of the behind the counter heroes in a sense. And are there specific myths that you would wish, you being a clinician, that you would wish to obliterate about the profession?
Yes, several myths. One is that they're trying to be physicians. They're not. Clinical pharmacists have a niche in collaborating with physicians and supporting, they're not trying to diagnose. I mean, there's some things that are you get trained to be able to understand, but that's not the niche of pharmacists. It's really to prevent adverse drug events and assure medication safety and to be there for clinicians when they're trying to figure out how to manage a patient. That would be the first thing. The second thing is that they get paid to provide the services that these services we're talking about. They don't get paid to provide these services. And unfortunately, the way that the economics have worked, you talked about this on your last podcast, they're incentivized to dispense in many scenarios. That's changing. It's changing because of the transformation I think that's happening right now in the profession with so many pharmacies closing, with Walgreens being acquired.
Right.
This really sets pharmacists free, I think, to pursue
Mm,
their real passion directly with patients and with prescribers without the pills. And I think that's a real distinction. I think having the access to the dispensing process is important so you can control the
right.
medication regimen for a patient,
Right.
but it's not required.
Mm.
Did I answer your
So if you,
question?
no, that was really profound. If you think about where the pharmacists are going now, giving all the disruption, is there anything else that you think a pharmacist can do within this sort of circle of care that they haven't been doing? And how does GalenusRx amplify that? How do they either facilitate it, amplify it, or make things better than the way that they were?
Yes, I spoke at the Digital Health Conference of the American Pharmacists Association 2 weeks ago in Nashville, and there was a speaker there from Canada. She blew me away. What they're doing in Canada, imagine us couple years from now when we're really have this tremendous nursing shortage, primary care provider shortage. That's happening
Yeah.
in Canada. They're down 100,000 primary care providers, 100,000 nurses. So all of a sudden, pharmacy is like, oh, wait, the pharmacist. So they are working really as the nurse practitioner era that happened here about 10 to 15 years ago is happening in Canada, meaning that they're working collaboratively with physicians. They're working at the top of their license. They're piloting.
Mhm.
If you can imagine, there's no healthcare providers, the pharmacists. Let's start paying them to just triage people and provide primary care under the physicians that are in the community. So being able to, and in the United States, there are collaborative
So
practice
as
protocols
as extenders in a sense, you're saying.
as extenders. And also, I would imagine that in that setting and in this setting, the way nurse practitioners are in many states, if not all of them, able to work on their own. I
Mhm.
would imagine that eventually will happen to pharmacists as well. There'll be the primary care provider role, which is the historical role of the pharmacist. It wasn't always that
Yes.
prescription existed. In in
Yeah.
all the European countries, the pharmacist is who you see when you're
It's the
sick.
first stop. I mean, I look at how things are in Europe, I look at how things are in Africa for sure that it is the first stop. As you've been on this journey with Galenus, I also just want to take a step back to think about the the impressive feat that you and the team achieved at Tabula Rasa and being able to find that product market fit. Have you been able to take some of those lessons of going through the wilderness and finding the right fit? How has that applied to Galenus, and where are you in terms of on that journey? Because you mentioned value-based care, you mentioned, pharmacists. I mean, at some point you're swimming further upstream with payers. Have you found there to be a fit, and what lessons can you glean from the Tabula Rasa days that you can apply to the Galenus days now?
Well, your whole career is a continuum, right? You just learn, 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 then you die, right? But I think what's really exciting that we're doing today is like when we started at Tabula Rasa HealthCare as Care Kinesis Pharmacy, as my co-founder Calvin Knowlton of Tabula Rasa HealthCare, his dad passed out in New York City after going to a Broadway show. And he went to the best hospital and they
Hmm.
put, 5 medications on his regimen that he'd never been on before. And by the time he got from New York to New Jersey, he passed out. And what the
Whoa.
concern was, well, why did this happen? And how could we have prevented it? So we did a pharmacogenomic test on him. It was like a $900 per gene at the time. Now, it's $170. You get all,
Hmm.
the genes, the drug metabolizing genes you need.
Right.
So it's much cheaper. And we started trying to get what was in the literature about sedation and anticholinergic burden. And we worked with, completely accidentally ran into our current co-founders, Jacques Turgeot and Vero McCod, who were both Michel in University of Montreal, because their company was called Intermed RX. And we
Mm.
were trying to get in touch with the person we had met whose company was Intermed HX. So we accidentally called the wrong company and found these people. So it was definitely destiny that we were to get
Wow.
we brought them in, we integrated their technology, which was multi-drug interaction technology. So we had kind of the pharmacodynamics, and we were looking for more of, the phenoconversion effect, even without knowing the genomics. What's the impact of a medication regimen on drug metabolism? And we were able to bring that in. So that really, and having all those little ideas of, well, here's your anticholinergic burdens out of the Rickenstroff Institute in Indiana, and this is your sedation burden out of Finland. And so we said, this is very confusing for providers and the pharmacists. Let's come up with the notion of a score. So we came up with the MedWise risk score at the time. And since we had transitioned, Jacques and Vero decided they would start from scratch and really use the basic sciences and come up with their own, the Rickenstroff Institute for Anticholinergic Burden had a dozen or so medications that were drying. And actually, there's 250 medications, and the dose is something we need to consider. It's not just
Mm.
25 milligrams of Benadryl is the same as 100. So all of that data being in the public domain and being able to put that together, we've actually been able to incorporate, pharmacogenomic data, which is what we do most of the time right now, is getting pharmacogenomic data integrated into our system, being able to apply it and
Mm.
translate it for the patient and the provider, so that we're personalizing their medication regimen. So I think that's what's been missing from
Mm.
the start of a one-to-one drug interaction system to really understanding this individual on these medications with this DNA. It's a research study of one person for every single person,
Yeah, that's a lot.
clinical
And
trial of one person.
who, as of right now, who finds that to be the most valuable? Have you found who has a sort of a propensity to want to incorporate that, to pay for that? What have you learned so far from all
One of
those
the things
different ones that you've
they
listed?
talked about, I'm sorry, Michael, I didn't mean to cut you off.
Oh, go ahead.
One of the things they talked about at the digital health conference was the notion of, we need payment for pharmacists. Well, pharmacists right now can charge whatever they want. It's the value they establish with the payer that they can establish. Once you get a payment for X, you're stuck with it. You're price taker. So pharmacy is already a price taker on
Mm.
medications. But a price setter environment is, how do you set the value? If you have a population and you're working with a REACH program or MSSP program, and they're at risk, or a PACE program, you know that they're concerned about those ER visits, hospitalization rates, nursing home admissions. I mean, all that is important. And I think also in hospice, being the classic value-based care environment, really their referral sources are concerned about what happens while they're on hospice, because that's part of the value continuum in the value-based care programs. So I think everybody in healthcare needs to, well, I don't say needs to, but they really understood that the major intervention that is taken in healthcare are medication therapy, and that
Yeah.
there's a way to really understand how to make that regimen safer using analytics. I think that there would be a lot fewer adverse drug events that are occurring, and people would save a lot more money and make a lot more money.
Yeah. I mean, why do you think things get stuck? I mean, it just seems as though that you're fed up with status quo and you're a disruptor and you build things to be able to make things better. Where do things get stuck? because I talk to a lot of different founders and some get more traction than others. But, sometimes when you're innovating, you're 5, 10 years ahead of the readiness of the market. And if you hang on long enough, you can catch the right wave and move that along. Have there been any signals for you and the team to say, hey, we're like 5 years ahead? And if that's the case, what do you do?
So it's not unusual to be ahead. And and pursuing a vision, a solution to a problem is the basics of entrepreneurism. However, if you're too early, then you need to pivot. You cannot wait forever for people to understand what you're doing or to need it or
Yeah.
to want it. And as much as they want it, if their payment cycle is so long that they're not going to see the value you bring for 18, 24 months, they're probably going to try and focus on something that can bring them value sooner.
Mm. But because you're such a large, I'll just say, chunk of what adverse reactions to medications mean down the line, does that bump you up higher on the prioritization scale of folks wanting to at least evaluate this seriously?
Well, there's some, like we're talking about misperceptions before. There's a misperception that medications don't matter in the accountable care organizations because they don't take Part D risk. And it's true, they don't take Part D risk. However, they get all the data in their files. They're coded with NDC numbers, and often they don't know what to do with it. What am I going to do with all these numbers? It's not, I can't even see the medications in this file.
Mm.
But we're able to translate that file and help them understand not just what impact you can have on the Part D medical, let's say medication costs, but it's really the medical costs, the medical cost curve that we're able to bend. So it is important. And that's the education. Often you have to induce a demand for the things you're providing, and
Yeah.
education is the way to do that.
How long did that take on the Tabula Rasa side of things? And do you see a similar sort of tale
Oh,
of
it
that
took us
happening
two
in
years
Galunus?
to really figure out the market we needed to be in. And things,
Mm.
often things are externalities. I find externalities to be a real pain. Things happen and it wasn't your fault. You didn't see it coming, and everything changes because of it. We thought that pairing clinical we had just had our company Hospice Pharmacia, and we had transitioned from that company after it was sold to Omnicare at the time. And we thought, oh, well, nurse practitioners in the home working with PharmDs and talking about medication management, nurse practitioners and PharmDs are great together. Um, However, and we'll build technology and we'll have it paid through the electronic, through the meaningful use dollars. Well, nurse
Yeah.
practitioners are not included. So that was our first mistake. And again, happenstance, we were staffing our nurse practitioners at a PACE program, and we said, let's go see what they're doing. Okay, it's enough that we're staffing the PACE program. George Hager, who is the CEO of Genesis Healthcare at the time, he had a
Mhm.
for-profit pilot, and we thought, well, George, can we go over there? And he said, oh, sure, go over, check them out. And we lent him our nurse practitioners because they didn't have providers. And it turned out that the medication process was really lacking. And just from the notion of a PACE participant is going to be at home, but go to a place every day, and they're going to get medications both at home and at that place. And how is all that going to be coordinated? So it was a really great challenge for us, but a complete, oh, let's stop by and see our nurse practitioners kind of a experience. So,
Right.
the more you get out of your office, the better. The
Yeah, I was
more
gonna say the main
opportunity you
lesson
have to
is get
see
out of
what's
the
happening.
office, stay curious, right? Go
Hmm.
in and there's only I just remember a long time ago, I would be taking a number of calls when people were trying to get into, at the time, Hanger Clinic. And I would say, hey, I'd say, time out. How much time have you spent in any one of our clinics? And I was amazed. 9 out of 10. Well, we really haven't. And I sort of say to them, how are you supposed to, how are you supposed to help if you don't know the environment? And so that's the one thing that, you mentioned is just, and I'd love to fortify it is for any of the founders that are out there, you can't just go off of a basis of assumptions that you've heard. You have to go and validate those yourself. And getting out physically into an environment, it might not necessarily be what someone says, rather it's what you observe and you take mental note of things.
even when you validate those, often when you get started, you miss something big. Like when we started at Tabula Rasa, we missed the need for communication with the provider in that their day from 7 to 4 p.m. is seeing patients. How are we going to communicate them by phone? So with them by phone. So we created which at the time was, novel, and now it's very typical. It was a secure way to communicate, kind of a chat process for recommendations and questions. And it worked great, but we had to get that up in 2 weeks. I mean, it was so critical that so you're always going to be finding and refining and one of the things that we've always found extremely important to our business model has been the notion of having people meeting with clients on a routine basis in person.
Right.
And
That's
it's
right.
okay to have a telephone call once in a while, but there's nothing like being in person with a client who will tell you things they may not say on a call, or they're feeling rushed and trying to get to their next call. So our the relationship aspect between the client and your business and the client is the most important thing to assure your future success.
Yeah, that is the currency. I mean, what I find fascinating, Ursula, is that you've been quite successful, multiple exits, and yet you continue to build inside one of the most complex and frankly fragmented, I'll just say fractured businesses, industries. Where do you find your why on the hard days, even after you've had such, presumably to an outsider, like a lot of worldly success? Where do you find the why when it's tough?
Well, you have to have a purpose. And I've never really found that playing golf is a good purpose. Or, you know, even even, it's just been in the culture of even my family to want to work hard and to want to make things better and to help people. And really what we do is all those things. So your purpose in life, no matter what you're doing, you have to find purpose in it. And that purpose has to be helping others in some way, I feel, in order for
Yeah,
it to really drive you.
that's right. That's right. You mentioned something earlier about being, having a lot of amazing mentors. And what's really encouraging for me is seeing more female disruptors coming into the space. It appears as though that it's still an uphill battle. What's the what's like the boldest thing you've done to pull others up with you?
It's a really good question. And I have been in a lot of meetings where I was the only woman in the room. And I decided that, and this was through a lot of listening to a lot of speakers and member of the women's business leaders, that it should never be that I'm the only woman in the room. So whenever we had a meeting and I looked at the agenda and the people attending, and it was just me, I'd invite one other woman, at least one other woman to the party. And we also had an internal communication that when a woman speaks in a room full of men, that at least one other woman amplifies what she just said. And
Mm,
the tone of the voice, there's something that like kind of filters out sometimes the pitch of the female voice, I think. Um, and I'm struggling a little bit, to be honest, still with when I say something, someone else has to repeat it. And it kind of is a little frustrating. So I'm thinking that maybe I should just say everything I say twice and that might have an impact. So no one feels like they have to explain what I just said. So
mm,
it continues to be, I feel very blessed that I always, having a PharmD and an MBA really got me to the business table. I don't think I could have gotten there without an MBA. And when our IPO roadshow came up, I said, look, I want to be on it. That just because it's going to be a lot of work doesn't mean I should be excluded.
that's
And
right.
a lot of
That's right.
days out of the office, away from our family. I was like, I really want to do this. So I wanted to show our team that, a woman can do this. It's not just the men of
Yeah,
the company doing
of
these
course.
things.
So if you were to just sort of kind of look back and have a conversation with the 27-year-old version of yourself that's just stepping into leadership, what advice would you give that 27-year-old self?
I was very much a bull in the China shop. And I would probably just tell myself that it's okay to listen and not act. There's no need to act on absolutely everything that needs to be fixed. Nobody likes a person who does that. It's a
Yeah.
challenge. It's a challenge being around someone who's always looking for something to fix.
Mm. What's the best way for folks to follow you, follow the work that GalenusRx is doing? Maybe just take a few moments here to kind of share a little bit more in depth about way folks can follow you and follow the awesome work that you and the team are doing.
Thank you, Michael. We actually just finished a three-series webinar, and I think being able to see that we did it with a physician's perspective, so a patient's perspective, and the pharmacist's perspective. We had two patients on our patient perspective program, and it's just a delight to hear how excited they are that their interaction with our pharmacists who are using our tools improve their lives. It's really incredible to think about, just two people who had a great
Right.
experience and how that could be impacted if everybody had that experience. How many
So when you're
surgeries
bu
do you avoid?
I love this. When you're building something, and we'll wrap up here in just a moment, but when you're building something, are you constantly building it with the voice of the patient in mind, or are you thinking about it from the voice of the clinician in mind, or both, or what leads that?
Definitely both. I mean, the for an ACO, the provider is everything, right? And the patients want to go there to be attributed to that ACO. So it's definitely both. And I feel that we really support the attribution aspect of it. People who really enjoy the experience and see GalenusRx as part of the practice, which is what we are, or GalenusRx as part of the hospice program. I think that that's a real key to satisfaction. And even, in my experience, whenever a clinician would move from job to job, they'd say, "Who else do you work with? I wanted to keep working with you. You're so helpful to what we do." And that is really a compliment.
Yeah, you're building something that's useful. And I could say that, there has been lots of press around things that have been lackluster. And what that means is that there might be some jaded clinicians, jaded organizations as a result of trying to adopt and implement new technology. It is a breath of fresh air to hear when you've built something that is meaningful and you have raving fans, and when someone leaves somewhere and says, "Hey, I'm leaving, but you know what? This tech is coming with me. I'm bringing it to my next place." That just shows that you built something that's actually very useful. And it's nice to hear that because you don't hear it every single day.
Yeah, well, we've been very blessed, and you learn things the hard way. So we learned the hard way, and we
Of
realized
course.
that the most important thing is that we're following where our clients are going so that they'll want us to go with them.
Right on. So for those that have tuned in, if you found this particular conversation useful, if you found it helpful, would you mind just sharing it on your social media, even just indicating, what golden nugget that Dr. Knowlton dropped today, because there were several, uh, resonated most with you. So it's great to see you, Dr. Knowlton. Thanks again for everything, and I'm looking forward to a next conversation.
Thanks, Michael. It's been such a pleasure. Really appreciate this opportunity to speak with you.
You bet.